Hello and good day. I am Christine and I will be presenting my clinical case study for mammography, which is MM05. A brief introduction about my case study. My patient is a 55-year-old woman with no history of breast cancer in the family. This patient also has dense breast even though she is already postmenopausal, and she is diligent about her checkups, and there has been found an architectural distortion in her recent mammogram. So as a radiographer, I'll have to decide what is the next step in order to confirm this patient's diagnosis. So an introduction to what is architectural distortion. Architectural distortion is a deformation of the normal structure in the breast with no definite mass visible. So this is an example of architectural distortion. It appears as spiculations radiating from a point and focal retraction or distortion at the edge of the parenchyma. Architectural distortion can be either benign or malignant, in which for benign it can be radial scars or sclerosing lesions. It can also be fat necrosis or post-procedural change. Meanwhile, for malignant, architectural distortion can be invasive ductal carcinoma, invasive lobular carcinoma, or ductal carcinoma in situ. These are the malignancies that are most commonly associated with architectural distortion in mammography. So, the procedure that I choose for this patient is contrast-enhanced digital mammography, which is CEDM. CEDM is a mammography procedure that uses iodinated contrast agent similar to those that we use in CT scan. So CEDM actually acquires images in dual energy, which is based on the principle that iodine in the contrast agent absorb X-rays differently at different energies compared to breast tissue. So in CDM, we will have low energy acquisition and high energy acquisition. For low energy, we use the kV values that we normally use in mammography, and the filter that we use is rhodium. So in this low energy image, it is similar to the 2D mammography, which is full field digital mammography images, FFDM. And in low energy, it will only demonstrate the breast parenchyma structures. Whereas for the high energy, we use high kV, which is 45 to 49 kV, and the filter that we use here is copper. So in high energy, this image will contain both the breast parenchyma and the adipose and the iodine concentration together. So from these two low energy and high energy image, there will be a digital subtraction performed, and the final resultant image will remove the breast parenchyma and the adipose tissue, leaving an image which consists of only the iodine distribution in the breast, which is also the contrast uptake in the breast tissue. So overall, in short, CEDM is a procedure that demonstrates tumor angiogenesis in breast cancer. CEDM has high sensitivity and negative predictive value, and it is also helpful in differentiating malignant and benign lesions. It also has comparable image quality to enhanced breast MRI, and it has high performance in women with dense breasts. The problem with imaging dense breasts is because dense breasts are more difficult to interpret and more difficult to detect cancer because the dense tissues appear white on mammogram, and this can mimic the appearance of lesions or obscure the lesions, so it is difficult to detect cancers. But since CDM has high performance in cancer detection for dense breasts, so I think CEDM is suitable for this patient since this patient also has dense breasts. The other procedures that this patient can undergo is ultrasound and biopsy. Usually for architectural distortion, ultrasound is used to see if the architectural distortion on mammography correlates to the findings in ultrasound. So if it correlates, then the patient will have to go for ultrasound guided biopsy. So for the patient preparation for CDM, before the procedures, the patient will be given appointment by the radiographer. Then the patient will also have to sign an informed consent form because there will be contrast administration for this procedure. Besides that, the patient will also have to take blood tests for renal sufficiency because if there is renal impairment, then this patient will be contraindicated to CEDM because it uses contrast. Then they will also take the detailed medication and detailed medical history for this patient to see if the patient has any allergic to contrast or if the patient has previous contrast media reactions to see if this patient really fits for CEDM. Then if the patient has good renal function and the patient is not contraindicated, so the patient can undergo CEDM. Then on the day of procedure, first we have to correctly identify the patient first. Then we have to ensure that the patient is not wearing deodorant, talcum powder or lotion at the breast area or the axillary area. Then the patient will be asked to change into hospital gown, remove the bra. Then breast examination is performed on the patient. Usually the radiographer will do this to locate any palpable mass and record in the mammography form. So for the imaging procedure, there will be two views for each breast. The two views are the same as normal mammography, which is CC and MLO projection. For CC view, this is the CC view, which is the view is from the top. So the detector is placed under the breast at inframammary fold level. Then the breast is pulled outwards until the inframammary fold is taut. Then the patient's head will be turned to the opposite side and adequate compression is applied. For MLO projection, this is different from CC because the tube is rotated 45 degrees so that the detector is parallel to the pectoral muscle. So for this position, the patient will be positioned so that the hips are anterior to the detector. Then the patient will have to raise their ipsilateral arm to shoulder level, then the elbows bent, the hand is gently raised onto the handrail. For this view, the breast tissue is lifted and pulled to bring the lateral portion of the breast to rest on the detector. And the upper corner of the image receptor or the detector should rest slightly posterior to the axilla. In this view, we not only take the breast tissue to be imaged, but we also have to include the posterior breast tissue and the axillary part. Then adequate compression is applied. For the imaging protocol, the contrast media that we use is non-ionic iodine contrast media, and we will inject this intravenously. The volume is 1.5 milliliters per kilogram body weight. So injection is given using power injector at a rate of 3 milliliters per second, and no breast compression will be given during the injection to facilitate the blood flow. After 2 minutes of the injection, then the first dual energy acquisition will be performed. So after 2 minutes, then only we can compress the breast, and the optimal imaging window for CEDM is 2 to 8 minutes post-injection, which means between these 2 to 8 minutes post-injection, which is 6 minutes, there will be 4 images taken. So first we start with the desired site first, then while the contrast agent has its highest concentration. For example, for this patient, it is the left side that is affected, so we will start imaging with the left side first, then we will image the right side. That's for the imaging protocol, and that is all from me. These are my references. Thank you.